in our patient. أنا دائما أسأل مرضاي أقول إيش رأيك بالإنسولين؟ يقول لي لا دكتور إذا خذيت الإنسولين معناه I'm gonna die. ليش؟ لأن it's end of my game خلاص. I took insulin, it's the end of diabetes and it's end of my life. I told him no, diabetes is going to give you, insulin is going to give you new life of delaying complications if you need it. So that's why we have to be very, very careful with our language. Okay? So philosophy of earlier insulin treatment, replacement of physiologically, as we said, achieving goals, reduction of complication, as I showed by hard evidence, you know, somebody who cannot take oral hypoglycemic agents and side effect with oral hypoglycemic agents. As I told you, polypharmacy, patient drugs, remember that most of hypoglycemic agents, they lower A1C by 1%, by most. Probably glucophage 1.5% and sulfonylurea 1.5%. But the rest of all our new medications lower HbA1c by around 1%. So there is continuous feeding to hyperglycemia in our patients. Our job is to stop this by decreasing hepatic peripheral and insulin resistance using glucophage and insulin, and also hyperglycemia, you have to stop it. So if the patient has hyperglycemia, giving him medications doesn't work. You have to lower his glucose, and then like people come to us sometimes. Last week I have a patient with an HbA1c of 16%. Which medication is going to work? Nothing. So he have to be on insulin till his HbA1c gets lower, and then you start insulin. Thank you very much. So any questions? Dr. Khadija?
Like an A1C of more than 9%, do we start insulin, or should we start it at a lower percentage?
Yeah, if you know, starting insulin, usually it's not directly related to the HbA1c. So if you have a patient who's newly diagnosed, HbA1c 9, by the guidelines you have to do combination therapy if he's first time. But if somebody who's already on medications and comes with a HbA1c 9%, depends on the patient. So I see my patient. If there is room for improvement in his lifestyle, for example, والله طالع من رمضان وقاعد ياكل صار له الحين شهرين ورهش وحلو وخرابيط هذه, and then he said, خلاص, I'm going to stop, I'm going to exercise, probably adding an oral agent will be fine. But if this patient is stabilized in his general physique and exercise and lifestyle, and his HbA1c is 9 and he's taking 2 or 3 oral hypoglycemic agent, if his HbA1c is 8, I would also give him insulin. If his HbA1c is 7.5, I would give him insulin. If he is actually maxed and he cannot do anything, probably this patient, I'll put some insulin and I withdraw some drugs, like for example sulfonylurea or TZD or DPP4 inhibitor. I told him, let's get you in control with insulin, withdraw some drug, get you less tablets, and then we'll get you better. So it depends on the patient.
Sometimes we give a combination of sulfonylurea with glargine. So that's okay, or should we just switch to the mix?
Yeah, you can use sulfonylurea with glargine. You have to avoid using old ones. As I said, use the new ones. Use short-acting sulfonylurea like Novonorm, because that will, be less long-acting and less hypoglycemia overall. And sulfonylurea, there are lots of studies showed if you use sulfonylurea with insulin, it basically lowers the amount of insulin you need. But if the patient is elderly, I would not use it. So I would not use it. I use it with a younger generation. If the patient is a driver or an active driver, I would not use it too, because the risk of hypoglycemia is high. Yeah. تفضلي دكتورة. Can we have here? Twice a day, yeah. Yeah. She's asking about using Lantus twice a day. طبعا Lantus I use it once a day all the time. rarely we use it twice a day. So our common practice is once a day. So I don't start Lantus with a 10 units, 5 units PID or something like that. لا. احنا we give Lantus once a day, but sometimes when the patient do this 4-point testing, and you see that at later in the day, between lunch and dinner, there is a big raise in his sugar. Probably that's because Lantus is not reaching. That's where we actually move to give him a cover with Lantus twice a day. Especially if the patient doesn't eat big meals. Like in the المريض eat big meals, I usually add short acting at lunch. لأن هذا will cover him till the next injection. So this is basically what we do. Sometimes patients require huge amounts of Lantus, like 60, 70, 80. Even the pen, one injection, the pen doesn't get it. Then we will split it into 2. There is no number, but usually higher, yes, 60 and above, probably I would split it. Yes, yeah. So you have to do the 4-point sugar. قبل الريوق, بعد الريوق, بعد الغداء, بعد العشاء. And then let him do it twice, and then see the numbers, and then you will know where is the problem. Then keep pumping Lantus will not help the patient if his postprandial is very high. So it's better not to increase Lantus or take it twice a day. It's better to add more short-acting insulin. Yeah, yeah. If she's taking big, like 3 injections of pre-meal insulin and she's still high, you have 2 options. You either split the Lantus or see where's the problem and adjust it in the preprandial. Maybe she's not injecting well. Maybe she's injecting in the same side. She have hypertrophy. Yes. So if there is no all of these issues, أنا شخصيا I either split the Lantus or change them to the Humamix 50, 3 times a day. But if it is available, yeah. تفضلي دكتور عائشة. ما في. Where is the mic? No, there is one on the back. She's more before.
What is the maximum dose of insulin we can give? Up to what?
Yeah, there is no maximum dose of insulin. I can tell you from my experience, the maximum dose I give to a patient was in Canada. It was 1,500 units a day. Okay. حتى أنا كنت خايف. فالكونسلتنت اللي كنت معه بالفellowship قال لي don't worry. And we used to give different kind of insulin with different concentration with a big syringes, and she was pregnant. She was a lawyer, أذكرها تماما. I wrote her case up as a case report. And حتى هو يقول لي دير بالك ترى أي شيء يصير فيها بترفع علينا قضية. But she survived the pregnancy well without macrosomia. She had severe rare insulin resistance. In Kuwait, my maximum insulin was around 300 to 400. I gave it to 2 of my patients who have lipodystrophy, which is a kind of rare syndrome with increased insulin resistance. Most of the patients, they require around 100, 100 units if they are morbidly obese. طبعا احنا نشوف الحالات الوايد يعني انتوا تشوفون lots of patients milder than what we see in the hospital. But to tell you, the idea is there is no sky limit for your insulin. But when the patient requiring insulin more than 100, then you have to ask yourself why this patient requires this amount of insulin. Maybe he's not taking enough glucophage. Maybe he's eating a lot. تمام? Maybe he's not injecting well. Maybe he have problem with the insulin I use. So I keep changing type of insulin with different mode of action. So we reach for this patient a specific solution. And you cannot just say, خلاص أنا أعطيته 60 وحدة وخليه I'm not going to do anything. And this is wrong. Okay. The only limitation for insulin is number of injections and hypoglycemia. So That will limit you. Otherwise, you can go ahead with increasing the doses of insulin. Sometimes الوايد مرضانا يخلون انسولين برا, so it's expired, it's not good, especially بجونا الحار هذا. So you have to look for things. I have one patient, I always tell it to my students and the lectures, who actually, when he go to the desert, his sugar goes up. When he come home, he's fine. He stayed in the desert 4 months a year. He have camels and stuff like that. So I just asked him, what do you do with your insulin? He said, خليه بالخيمة. That's what he do. I told him, anybody told you about this? He goes, ما حد سألني أصلا. Nobody asked me. أقول له ما عندك ثلاجة؟ يقول عندنا إحنا هناك كامل يعني عندهم فريزر وثلاجة. They are living like normal people. Then he starts putting it in the fridge and his sugar come down. So you have to look for your patient. تفضل دكتور.
When I ask the patient to do his self-monitoring, most of my patients come with different fasting blood glucose. Sometimes he has 2 readings of 10 and 1 reading of 6, or postprandial 3 readings of 12 and 1 reading of 8, like this. So do I have to adjust the dose according?
Yes. You know, when you have the way to read the log of a patient, you don't respond to a single number. We respond to a trend. So when you look at the numbers, you look at the trend. If there is no trend, means you cannot take these numbers seriously. So the first thing you ask the patient, if the patient's having 8, 8, 8, 8, 8, 15, that means this 15 is out of scope, so I will not consider it. So I consider it 8s. Or I ask my patient, what did you do this day? Most of the abnormal fasting glucose, especially for patients who take insulin or sapphire, is midnight hypoglycemia. Okay? So you have to think about اللي هو السموجي effect أو midnight hypoglycemia. لأن وايد أوقات المريض they get this and then you keep adjusting the insulin and they get more hypoglycemia. Always put that in your mind. It depends على وايد أشياء. Meals is very good to ask. وايد مرضى عندنا يأكلون آخر الليل something and he think it's nothing. قطعة الرهشة هالكبرها ولا حلوة ولا بالليل قعدت شرب سيجارة خذيت معها قهوة وحطيت فيها شكر مثلا. You know, looking at these numbers is a tricky thing and needs concentration and needs to look for a trend where you have to ask the patient, what's happened here, what's happened there. The patient smart enough, he will remember. يقول لك لا والله ذاك يوم كنت معزوم. فأنا I tell him وقت العزيمة will give you another regimen compared to this daily. طبعا things like sensors or AGB, the ones we saw before, like help the patient, help the doctors more to make decisions in terms of looking the whole blood glucose throughout the day, and hopefully this will become more available and help us more.
Can we preserve beta cell function if we start insulin very early in type 2 diabetes?
There are few trials looking at starting type 2 diabetes with insulin pump. So the moment the blood sugar is 7 or nearly touching 7, first diagnosis, first thing you give them, insulin pump. And then they followed the patient and they found that the chances of the beta cell dysfunction is actually delayed. So you have insulin sensitivity is better when you use early insulin. طبعا في lots of work about this, but there is no evidence in how long, or most of the studies they give insulin for 6 months and then they saw the decline in beta cell. They saw it's actually the decline is slower than the others. But this is not something that we can use as in our daily practice. There are many people who use insulin. I know many of patients I saw in the States, and I have one of my patients who actually he's type 2, but he started insulin the day of diagnosis, 30 or 40 years old. And he's still on the insulin. And he liked it. He said, Anna, the safest drug in the world is insulin. I'm not going to take anything else. And he's fine, and his HbA1c is below 7, and he's happy. So at the end, it's HbA1c. If the patient is okay with taking insulin, it's fine. If the insulin is nebulized now, if you give your patient nebulized insulin, Probably they will accept it more injection, but it's still not available. So starting insulin early there is some favorable epidemiological evidence, but we don't have a long-term evidence. اتفضل.
You mentioned that we start insulin first, example in acute damage, for example, MI, for a short period of time, then we can taper it and we add other anti-hyperglycemia. Can you just tell me how long we can give short, short period?
طبعا the studies showed that they use it at least 1 year. 1 year to get the benefit of reducing the risk of developing, a second MI. So if anybody with acute MI, in our hospitals, when they go up, we send them with basal insulin most of the time. And then we give them follow-up, and then with time, they require only glucophage and basal insulin.
During this 1 year, we don't add metformin? And after 6 months, we don't add metformin?
Metformin, we add it from the day of diagnosis.
For the acute MI.
Even acute MI, you give them metformin. There's nothing wrong. So metformin is safe. GLP-1 mimetics are safe in acute MI. There is big studies about that. DPP-4 inhibitors also safe to be used, although there is no evidence in that they help with the reduction of ischemic heart disease. Sulfonylureas probably you have to avoid in somebody with acute MI. And usually we actually get away from them toward insulin and metformin. Okay. Thank you very much. عندنا السحب الأخير قبل لا نمشي on the edge. دكتورة زينب السحب. Okay. دكتورة زينب تقول إن شاء الله تطلع للنساء، وأنا أقول إن شاء الله تطلع للرجال. ما راح اسحب، اخلي واحد يسحب. يلا اسحبي. بسم الله عليه توكلنا. دكتورة إيمان الشيخ. يلا مبروك. لا وقاعدة بأول سطر، أكيد مش متفق معاها. الحمد لله. إن شاء الله دائما حظك حلو. Thank you very much for coming. Thank you for staying. Inshallah, we promise you this is going to be a yearly exercise, and we want your input. أنا موجود، دكتورة زينب موجودة. We're happy to have your input. And inshallah next year, احنا السنة رتبناه بشكل سريع. Next year we're going to start actually from today to prepare it. And صراحة it will not work without you. So into the stars the last 2 days. Thank you very much.